Dr. Decker mentioned earlier that we're seeing increased effective contraceptive use, including expanded use of long-acting reversible contraceptives, or LARCs. And our next two speakers will discuss an innovative effort to expand access to LARCs in Colorado. First, we will hear from Dr. Larry Wolk, Executive Director and Chief Medical Officer for the Colorado Department of Public Health and Environment, who will be sharing the Colorado Family Planning Initiative. Dr. Wolk?
Thanks, Catherine, and good afternoon, everyone. I'm going to start off a little bit differently by showing kind of the slide of conclusions up front. Really at a glance, our Family Planning Initiative started in full force in 2008 and has been going strong up until 2014 and continuing through this year as we look for continued funding. But over that period of time, provided over 36,000 LARCs to low-income women across the state. The results were a drop in the teen birth rate by 48% over the 5-year period, and a concomitant fall in the teen abortion rate of also 48% over the same 5-year period. Medicaid cost avoidance at a median of about $79 million in related health care costs over the first 3 years of the Family Planning Initiative, and that's against a cost of the program which is about $27 million over 7 years. So about a 3-to-1 or so return on investment, most conservatively, although other estimates show that that return is quite a bit greater. I'm going to focus on some of the things that we've learned and will continue to build upon as keys to the success of the program, one of which is ensuring that we have training for healthcare providers, that it's not just enough to have the LARCs themselves. Support for operational infrastructure for clinics and practices and sites that are involved in providing LARC. And then trying to reduce or eliminate the cost of LARC, whether through insurance coverage or lower cost options, and we'll talk a little bit more about that. So if nothing else, like I said, started with the conclusions, and let me rewind a little bit. So as I said, this started about now 6 or 7 years ago, and the objectives really were to not just put LARCs without obstacles and available to any young women who sought them, primarily those who were uninsured, underinsured, living in poverty, at risk. But to increase access to services and to LARC by also improving provider training, and then also through a public education campaign, ours entitled Before Play, which really incorporated to Evelyn's comments at the beginning, how you speak to teens, how teens speak to each other, and how you put this in the context of an overall adolescent health message is critically important to the success. From a funding standpoint, we were fortunate enough to have a private foundation interested and then going ahead and funding us to the tune of the $25 million or so over a 5-year period. And we decided to go ahead and distribute to all of our Title X funded agencies and clinics is the easiest way, for a number of reasons that I'll get into in a minute, to get the program up and running as quickly as possible. We had 69 family planning clinics participate. These are located in 36 counties. Colorado actually has 64 counties, and I'll show you a map here in a minute. But 95% of the state's population is residing in the 36 counties who had access to this program. And then the other note is 42 of the 69 clinics were located in local public health departments. So what a wonderful way to align healthcare services with population health and public health so that we could incorporate our local public health agencies is really primary providers for this important program. I promised a map, and here it is. Might be a little difficult to see, but Colorado, like many states, has an urban corridor in and around the Denver area and what we call the Front Range, and so the majority of the population and therefore the majority of the clinics are located within the urban corridor and up and down the Front Range. Having said that, I hope you'll also be impressed with the number of rural sites scattered throughout the state. So this was not just focused on the urban underserved, but really on the rural as well. And when I get to the overall numbers and the roll-up of those numbers, what's most impressive is when you look at these rural counties, how many of them had significantly greater rates of reduction in teen pregnancy and abortion as compared to their counterparts who did not participate in this program, who did not see that kind of rate reduction. We call this a game changer, even if you don't look at the roll-up numbers or the modeling for the return on investment. Let's just look at good old-fashioned utilization. The Title X based LARC insertions in young women 15 to 24 went from 0.5% in 2008 to nearly 10% in 2014. The IUD and implant use amongst the same population went from 4% up to nearly 30%. And then the concomitant decrease then in oral contraceptive use from 44% down to 30%. And then you see the state fertility rates per thousand for all women 15 to 19 going from 40% or nearly 40% down to 19%. And this just represents that then graphically. Colorado really had nothing to be proud of with regard to our teen pregnancy or birth and fertility rates. Back in 2007, we were amongst the 10 or 15 worst states with a birth rate of 40.2. But you can see now we're amongst the 10 or 15 best states with a birth rate down to 19.4. So again, this is the roll-up of all teens across the state. And so we've been able to demonstrate, and I won't steal too much of Jason's thunder, with regard to the impact that the Family Planning Initiative had on the overall and total number of births and fertility rates across the state. And then I touched on a couple of the secondary impacts. Like I said, I think clinically and politically, it's important to make sure that we're obviously educating our elected officials as well as the general public with regard to LARC not being abortifacient, if that's even a word, but regardless, when you listen to and talk to the opponents for this kind of program, it's very helpful to be able to say that this program really contributed to a dramatic reduction in the teen abortion rates statewide. We've seen a secondary reduction in WIC infant enrollment across all ages. And then I talked about the median Medicaid costs averted. Following a number of other impacts, people often ask about sexually transmitted infections, STIs. Colorado actually has seen somewhat of a leveling off, if not a decrease, of STIs amongst this same population, in spite of what may be a national trend toward an increase. But certainly, if there is any increase in Colorado, it's not amongst this particular population. We're also following infant mortality rates, and those have seen a steady decline from 6.3 per thousand in 2009 to now 5.1 in 2013. So not yet ready to declare that as a result or a direct result of the Family Planning Initiative, but certainly some other metrics of interest for us as we look at the total population health impact. So with regard to insights and lessons learned, I mentioned at least starting off by partnering with existing systems. Title X funded clinics and federally qualified health centers are certainly well equipped philosophically to be able to handle the population and to be great partners in working with us in getting LARCs out there and getting them utilized. Having said that, a lot of other healthcare providers exist in the community, and you heard some of that through Mara with regard to school-based health centers and private practices and other places where teens and young women access services. So next step here is now to take what we've learned relative to Title X and FQHCs and move that now to the greater ambulatory care provider network. Champions are very key to meaningful change. There's a lot of folks out there who would say that, oral contraceptives, it's a lot easier to prescribe. It takes a lot less time. As a healthcare provider, I'm a pediatrician myself, so I can certainly relate to the the practical aspects of this, which are if I only have, 8.5 minutes to see a patient, it's easier for me to write a prescription for oral contraceptives or hand out condoms rather than to take the time and plan and work through and be appropriately trained, let alone, billing and coding for something that I may not have received formal training for as part of my pediatric clinical and residency training. So, really relying on the champions to demonstrate that this is cost effective, that there is a way to bill and code for this, and that this does follow the best clinical practices and guidelines, and to use data to guide your decisions really does help kind of stem the tide here and get folks to change their clinical practice. And, as I said, having LARCs available in all clinical settings and not just Title X funded clinics or FQHCs, I think will allow us to continue to see the decline in the unintended pregnancy rates and abortion rates. I think inventory management is critical, having same-day insertions. It's wonderful that many of these providers offer some sort of subsistence plan for folks who are uninsured, but waiting for a LARC to come in 6 weeks after you're seeing a patient, or sending someone even to a pharmacy to pick something up because of issues as it relates to coverage by payers, it doesn't work well for this population, and I don't have to tell this group of participants that. So I'm envisioning down the road some sort of VFC-like program for LARC where we can create a centralized inventory management program so that every provider doesn't have to be out the money to invest in LARC, to have an inventory on hand, and it could work the same way the Vaccine for Children program works, only we're talking about LARCs this time rather than immunizations. And then increasing knowledge amongst clients. It's very important, and it worked well for us to really get the word out and have young women talk to young women about how these are not your mother's IUD. These are different than what was available, even 10 years ago, and to talk about some of the myths and dispel those myths and really gain this groundswell of public education amongst this population. And that also includes making sure that confidentiality is preserved and having supportive consent laws. It does raise an issue, as many of you know, with payers, because we are an ACA state, so some people will say, well, since you're an ACA state with Medicaid expansion and with commercial insurance available through an exchange, everybody should have access to insurance, and all insurance should cover these. Why do you need general fund or grant or whatever else, to cover these things? And obviously there's a number of barriers, not the least of which is that there are still, of course, young women who are uninsured or underinsured. Some health plans are not defining LARC appropriately and will call LARC, a vaginal ring or a contraceptive sponge rather than an IUD or an implant. The reimbursements sometimes are not correct. Most health plans don't have a mechanism to allow for confidential services to be obtained by a teen who may be covered under their parents' insurance. Some insurances even have prior authorization still in place where you have to have failed an oral contraceptive or some other form of contraception in order to qualify for LARC. So better than it was and certainly less reliance on subsidy. I will say that 5 years ago we had a $500,000 statewide through our Title X funded clinics in insurance reimbursement. 5 years later, that's up to almost $4 million. So less reliance than on grants and subsidy as more and more insurers are covering LARC and covering LARC appropriately. So I just want to thank my colleagues in our Colorado Family Planning Initiative, most notably Greta Klingler and Jody Camp, who really are the masterminds behind the project, and I just happen to be in the right place at the right time, and very grateful for not only their help in preparing the slides, but in having a very successful program for teenagers and young women in our state. Thank you.